Blueprint. Today we're walking through the Medicare Telehealth Policy Roadmap from 2026 through 2028. This is a major transition period. We're moving from broad pandemic-era flexibility into a much more restrictive statutory environment starting January 1, 2028. Think of this as the journey from now to the 2027 cliff, and then into the new normal. Quick disclosure. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or coding advice. Always follow official coding guidelines and your organization's policies when assigning codes. Through December 31, 2027, we're still in a period of flexibility. Beneficiaries can receive telehealth from anywhere, including their home. The list of eligible providers is broad, and audio only is widely permitted. But on January 1, 2028, we hit what CMS calls the statutory era. This is where restrictions return. Geographic limits come back, the home is generally removed as an eligible originating site, and the list of eligible providers shrinks. The one major exception is behavioral health, which keeps permanent flexibility. Through 2027, there are no geographic restrictions. Patients can be located anywhere, and the home counts as an originating site. But starting January 1, 2028, the rural requirement returns under Section 1834, M. Patients must be in a rural area and in a medical facility. The home is generally no longer allowed as an originating site, except for behavioral health. Through the end of 2027, a wide range of providers can furnish Medicare telehealth: physicians, NPs, PAs, clinical psychologists, PTs, OTs, SLPs, audiologists, and more. But starting January 1, 2028, several of these specialties lose telehealth billing privileges. Physical therapists, occupational therapists, speech-language pathologists, and audiologists are excluded from Medicare telehealth under the statutory rules. This is a major workforce planning issue for organizations. Behavioral health is the big exception to the 2028 restrictions. Thanks to the Consolidated Appropriations Act of 2021, behavioral health telehealth is permanently decoupled from geographic limits. Patients in both rural and urban areas are eligible, and services can be delivered in the patient's home permanently. Two-way audio, video is allowed, and audio only is permitted when certain conditions are met. For behavioral health, there's a recurring in-person requirement. Patients must have an in-person, non-telehealth visit within 6 months before their first telehealth service, and then every 12 months after that. There are a few nuances. Patients already receiving mental health telehealth before January 1, 2028 are grandfathered in. Exceptions are allowed when an in-person visit isn't possible. The visit can be completed by another clinician in the same group and specialty. Through 2027, hospitals can bill for certain remote services delivered to the patient's home, things like outpatient therapy, diabetes education, and medical nutrition therapy. After 2027, hospitals can no longer bill for these services when they're furnished remotely to the home. On the teaching physician side, virtual presence is now permanent. As of January 1, 2026, teaching physicians can supervise via real-time audio, video during the key portion of a telehealth service. For RHCs and FQHCs, we have two different timelines. Mental health visits keep permanent flexibility. They're paid under AIR or PPS, audio only is allowed, and the in-person requirement doesn't apply until 2028. But for medical visits, non-behavioral health, the flexibility ends earlier. These visits are billed under G 2025, and that code expires December 31, 2026. So this is an earlier cliff than the general telehealth expiration. Starting January 1, 2026, direct supervision can be met through virtual presence using real-time audio and video. Audio only doesn't meet the requirement. This applies to incident-to-services, diagnostic tests, and pulmonary or cardiac rehab. And CMS has permanently removed frequency limits for subsequent inpatient visits, nursing facility visits, and critical care consultations. Beginning in 2028, audio only becomes a behavioral health-only exception. Here's the logic. If the service is behavioral health and the patient is at home, audio only is allowed, but only if the provider is capable of video and the patient either cannot use video or declines it. If the patient can use video and agrees to it, then audio, video must be used. This applies to both new and established patients. Telehealth billing relies heavily on the place of service code. POS 02 is used when the patient is at an originating site like a clinic or hospital. This pays at the facility rate. POS 10 is used when the patient is at home. This pays at the non-facility rate, which is higher. So using POS 10 is key for payment parity. A common question is whether providers need to list their home address publicly if they're practicing virtually. If the home is the only practice location, it must be enrolled. But CMS allows you to mark it as home office for administrative, telehealth use only. When you do that, the address is suppressed on the Care Compare website. So privacy is protected. Clinicians participating in certain Medicare Shared Savings Program ACO tracks get special telehealth flexibilities. If you're in an applicable ACO, you can furnish telehealth to assigned beneficiaries without geographic restrictions, and the patient's home is allowed as an originating site. This applies to the Enhanced Track and Basic Tracks C, D, and E. Not all remote services fall under the telehealth rules. Some services are inherently non-face-to-face and are not affected by the 2028 Cliff. These include RPM, CCM, Community Health Integration, Principal Illness Navigation, and Behavioral Health Integration. These services continue uninterrupted because they're not substitutes for in-person visits. To wrap up, here are the key dates. February 10th each year, deadline to request changes to the Medicare Telehealth Services list. December 31, 2026, expiration of G2025 for RHC, FQHC medical visits. December 31, 2027, the major telehealth cliff for geography and provider eligibility. And for administrators, the to-do list includes verifying rural status for 2028 planning, tracking behavioral health in-person visit loops, and reviewing staff credentials against the 2028 exclusion list. Thank you for watching, and I'll see you in our next video.